So most of my work is more related to clinical outcomes, looking to see if the interventions that we're engaging with patients are truly resulting in improvement in their functioning. Sure. So a lot of the patients that we see, particularly in our inpatient program, they come in on very high doses of opiate medications, and over the years they've come to rely on the medications and perceive them as the only tool that they can use to manage their pain. In our program, we try to help people optimize their use of medications and teach them behavioral ways of managing pain, non-pharmacologic tools. We have them work with occupational therapy, physical therapy, psychology, all in an effort to try to achieve higher quality of life without relying on drugs. So looking to see if those interventions that we're implementing are having the stated effect. So our program is called the Stanford Comprehensive Interdisciplinary Pain Program. It's an inpatient pain management program, and the average length of stay is about 5 or 7 days. So it's a relatively brief period of time, but we're able to do some intensive work with helping patients start the process of cleaning up their medications and putting them on a healthier path to managing their pain. So we don't see any pediatric, it's purely adult, but we get the full range of ages, anywhere from 18 to into their 90s. Not really in this sense. I mean, there are certainly differences in the two demographics in terms of emotional distress, other risk factors, things along those lines. But as far as the actual tools that we teach, it's all very individualized. You know, a 90-year-old person who's relatively new to the arena of pain, who's looking for anything to improve quality of life, may be more open and receptive than somebody who's younger, who just wants to have a quick fix, or vice versa. So we never really know what to expect. We just work with each person individually. So I have 3 talks at this meeting. The first one is how to manage a chronic pain patient using an interdisciplinary team, and I did that as a representative for the American Academy of Pain Medicine. I had that this morning. Later this week I have a talk with one of my colleagues, Dr. Jennifer Ha. We're going to be talking about interdisciplinary management of pelvic pain. And later in the week, another talk with Dr. Ha, where we're going to talk a little bit more about cessation of opiate medications, and I'll spend a little bit of time in that talk discussing our inpatient pain program. So I think that the pendulum swings pretty far, where, you know, there was a time in the 90s where it was you medicate people until they have no pain, and now we've swung in the other direction, where there are a lot of clinicians who, even for acute pain, are fearful of prescribing opiates at all. So I think that the reality is somewhere in between. I think that there's certainly a role for medications. I'm not saying necessarily in acute versus chronic pain, but I think certainly with the opiate medications there can be a role for these, but just need to have a lot of caution and need to make sure that with chronic pain patients especially, that any use of any drug, be it opiate or non-opiate, is done in a true multimodal fashion, where you have a patient working on both the pharmacologic and non-pharmacologic intervention. You know, I look forward to seeing some of the other talks. I haven't had a chance to peruse the program, but I do want to see other talks, see what other people are doing, and see how I can bring their best practices to our clinic so that we're not all reinventing the wheel, but just doing the same thing.